Okay, let's talk about the trigeminal system. It's probably the biggest cranial nerve. The trigeminal ganglion is going to give off fibers that innervate the supratentorial dura. V1 is going to exit via the superior orbital fissure. V2 via foramen rotundum, and V3 via foramen ovale. So superior orbital fissure, foramen rotundum, foramen ovale. V1 and V2 are going to travel through the cavernous sinus. There's another view of V1, 2, and 3. 1 and 2 are going to travel through the cavernous sinus. So let's focus on the ophthalmic nerve, V1. It's going to enter the orbit through the orbital fissure, and it's going to supply sensation to the face, specifically the upper eyelid, the upper nose. It's also involved in the afferent limb of the corneal reflex. The maxillary nerve, V2, is going to be involved with sensation also. It's going to be the lower eyelid. So V2 is lower eyelid, lower nose, and then upper lip. Upper mouth and upper teeth are all V2. V3 is going to be sensation to the lower lip, lower jaw, lower teeth. That's all V3, mandibular. V3 is also going to innervate the tympanic membrane. It's going to give sensation, it's going to pick up sensation from the anterior 2/3 of the tongue, so not taste, sensation. And it's going to come from the TMJ joint. The mandibular nerve, V3, also provides motor to muscles of mastication, and it's going to use the motor nucleus of cranial nerve 5. So it's located in the lateral mid-pontine tegmentum, and it's going to receive input from both left and right cortical bulbar fibers, because this is an important part of survival, so I think of it that way. But if you get a lesion of the cortical bulbar fibers on one side, it's not going to completely wipe out that side if it's cortical bulbar. So it's going to supply muscles of mastication, the masseter and temporalis. So here's our masseter, here's our temporalis. It's also going to supply the lateral and medial pterygoids. So the lateral pterygoid, so here's our lateral pterygoid here and our medial pterygoid. The lateral pterygoid's kind of special because it acts to open and protrude the jaw. And when you denervate it, when you cut, it's going to deviate to the side of the lesion. So here's our lateral pterygoid and our medial pterygoid. Another view here and here. This is a nice view because you can see that this is more medial here. This is more lateral. V3 also innervates the mylohyoid. It's right here. The submandibular gland kind of wraps around it. It innervates the anterior belly of the digastric muscle. Here's anterior, here's posterior. So anterior belly of digastric, and the tensor tympani, this muscle here. If you paralyze it, it's going to cause hypoacusis, which means you don't hear low-pitched sounds. Another muscle that it innervates is the tensor veli palatini, this muscle here. Big arrow. So pathways, the trigeminothalamic pathways. First order neurons are in the trigeminal ganglion. It's then going to send projections, and if it's a little different whether or not it's epicritic or protopathic sensation, but epicritic is going to rise on the same side and enter the ventral trigeminothalamic tract. The protopathic sensations are going to first descend a bit, and then they synapse and cross to the other side, and then enter the dorsal trigeminothalamic tract. Both are going to project to the VPM of the thalamus, And then the third order neurons are VPM of the thalamus, projecting through the internal capsule to the cortex. Trigeminal reflexes, we've got corneal involved here. The afferent part is ophthalmic branch, and then efferent is facial. We have tearing, which is ophthalmic, and then efferent is facial. The oculocardiac, the ophthalmic is afferent, so you push on the eye. On the pressure on the globus is going to cause bradycardia by stimulating the vagus nerve. And then jaw jerk, it's a monosynaptic, so we have the afferents being mandibular, and then the efferents also mandibular, because you have two different types of nerves in there. So we talked about the corneal reflex. It's going to use the spinal trigeminal nucleus. We have the afferent fiber from V1 going to the caudal spinal trigeminal nucleus, and going to synapse. And the efferent fiber is going to be from facial nerve to orbicularis oculi muscle. Jaw jerk, afferent is mesencephalic, so it's going to come in and synapse on the mesencephalic nucleus, and then give off its efferents through the motor nucleus of cranial nerve 5 trigeminal. Some problems: trigeminal neuralgia. These are paroxysmal sharp stabbing pains. They occur in women more than men, age greater than 50. Treatment is carbamazepine if it's idiopathic, if you don't know what's causing the irritation of this nerve. Cavernous sinus, V2 and V3 run through it, but also cranial nerves. Okay, so if we follow these numbers here, we've got cranial nerve. On the lateral wall, we've got cranial nerve 3 and 4. We have cranial nerve 6, that's a little more medial, and then V1 and V2. We also have the autonomic plexus around the carotids, and the carotid's going to be around the carotid siphon. We've got the pituitary gland, and the base here is the body of the sphenoid. So what happens here is you can get this cavernous sinus thrombosis. Usually this is from an infection in the danger triangle, and a lot of times it can be like a tooth, an upper tooth that gets infected, and that's what happened with this gentleman. He had an upper tooth that got infected, and he got thrombosis of his cavernous sinus, and it causes it's going to cause nerve palsies of these nerves that are involved here, and it can also cause headache. And that's it.